Welcome everyone. Delighted to have so many people with us this evening. So, by way of introduction, my name is Dermot Brannock. I'm the Director of Academic Affairs with IHED. I'm joined this evening by a number of my colleagues in IHED and by Professor Stephen Lawrence, who is our Programme Director in the University of Warwick. So, the format for this evening, we've got as well some students that are currently undertaking the programme, and we'll actually start with a brief conversation with David and Paula, if she's here, just about their experience on the programme, and then Stephen is going to give us an overview as to the current state of diabetes and how this programme prepares you to be a better practitioner delivering diabetes care, be that as a doctor, a nurse, pharmacist, a dietitian, etc. And then I'll give a talk about kind of the structure and overview of the programme. For those that are joining, microphones are off because there's so many people on, but there's a chat function down the bottom that you can use to ask any questions. There's a number of the team that'll be responding to that throughout the evening, or kind of fielding questions to us that everyone might have an interest in. I think Paul is in as Ronan Coffey. Quiva, would you do the needful there? I suppose I'd like to start. I'll introduce David Thomas, who is one of our current participants on the programme. I hate using the word student for someone that's a qualified doctor and tons of experience under their belts. David, you're a busy doctor. You've been at the coalface of COVID for the last number of months. What made you interested in taking on a postgraduate qualification in diabetes?
Well, again, I was already interested in diabetes. I was already sort of taking on the lead in our practice, and you get to a point in your career as a GP, at least anyway, where you want to start and branch out a little bit. There's only so much of the same sort of bread and butter GP you can do sort of 4 or 5 days a week. So everyone tends to end up sort of sub-specialising into something. Diabetes had really taken my interest. There's the advent of primary care networks in the UK now, meaning that you've got smaller groups of practices, like 5 or 6 practices working together. We're looking at things like diabetes from that point of view as well. So it's a way of me of branching out away from daily general practice into doing something on a wider level for my community, for a bigger number of patients, potentially in the future, sort of, taking a lead for our area, for our region with our CCG. So it's just something that I think that will, well, it's massive. Diabetes is huge. It's an ever-growing problem. It encompasses everything. It's pretty much everything that you touch in general practice day to day has got some kind of link to lifestyle. That all ties in with diabetes. So I just thought I wanted to get some backing behind what I'm doing. So I wanted to become sort of a GP with an extended role, and something like this as an online course is perfect for that, really.
Yeah, that makes absolutely tons of sense, and you're right about the lifestyle behavior change that's needed, and just the prevalence of diabetes. And this program initially started in the Middle East before actually coming back to UK and Ireland. Obviously, the prevalence rates in the Middle East are astronomical, but we can see the same trend here, and I'm sure Stephen will talk to this. How have you found, David? How have you found balancing? Everyone that does this program they've got a full-time professional role in a healthcare environment, and they're part-time students. How have you found the juggling act, especially over since March when everything's gone haywire?
It was tricky to start with, because I think we started in the first week when the UK went into lockdown.
Yeah,
really kicking off. So that was quite tight because we were very busy in work. But you just kind of get into it. You get into a rhythm. You find, Sunday morning is study time, and Tuesday evening is study time, and then we have the tutorial once a week. But because it's online, you can dip into it. If you happen to have sort of a couple of hours free in your day, you can just go online and just have a look at some of the work for that week, or just, you know, add something to the discussion forum for that week. So it's just so readily available. And we're all now experts at using online platforms, Zoom meetings and MS Teams meetings. So it's just so easy to get on with without having to go anywhere. I think if I had to go to, like, even my nearest university would be Liverpool, but trying to do a course like that just with that distance, I'd find that quite difficult, if not impossible, I think.
And it's funny that the theme you bring up is one that I kind of talk about an awful lot, which is rhythm. And like what you said there, but Sunday morning or Tuesday evening is a dedicated study time. And I think having that discipline that you can, not only to yourself, but you can say to all the people around you, to your family, to your colleagues, kind of, I'm locking myself away in a room on a Sunday morning from 9 until 11:30, and that's that chunk done, and then I'll do the same on Tuesday evening. And it allows you to compartmentalize it, and in the same way that we've all gotten used to having to discipline ourselves while working at home, that you don't let things bleed into every aspect of your life. It's critical that you do that with study as well, that you split out, right, this is dedicated study time, and then when I'm with my family or whatever else, that I'm fully focused on that. Paula, could I ask you, you've got a slightly different perspective. You're a nurse in Ireland. What made you want to undertake the program? It's a different motivation, I think, possibly from David's perspective as a general practitioner. Oh, Paula, we can't hear you there. I don't think you're muted. Can you try it now? Oh dear, no, I'm not hearing you, Paula, at all. Can you? Hang on. Try it now, Paula. Okay. Paula, I tell you what, Ian will chat to you in the background and try to get your audio working, and we'll come back to it if that's okay. The reason I was going to bring Paula in at this point was as a nurse, but David or Stephen, both of you, how do you, this course is a huge interprofessional mix. There's everything from GPs to nurses to dietitians to pharmacists. Not in the UK or Ireland, but in Malaysia we actually have some endocrinologists on it. We have a cardiac consultant. How do you find the mix of professions in the one program works? Is it an interesting addition? Is it a benefit, or what's your perspective on it?
I perhaps I can give the viewpoint of a tutor on this, and I can say that the multidisciplinary approach, whereby you have, as you said, Dermot, nurses, pharmacists, dietitian, doctors coming together, actually enriches the discussion. And we often find that the way in which we are trained tends to some degree dictate the approach that we might take towards managing a condition that, after all, has multifactorial elements to it. It therefore means that each participant is actually benefiting from the inclusion and the contribution of others. So I normally have a rule, it's a very simple rule, is that there is no such thing as a silly question, because it will be appropriate from your point of view, from the direction of your training and your experience. I don't know how David has found that in his experience as a delegate, as a candidate.
No, I totally agree. It's you see totally different viewpoints and things that didn't even cross your mind, as certainly I do as a GP. I mean, we've even got a deputy head teacher of a hospital school on our group, and he's telling us about dealing with 7 and 8-year-old kids being diagnosed, and it's just something that you just never see. There's aspects of diabetes and just healthcare that you never even knew existed, or it didn't cross your mind. So I agree, it's very enriching hearing other people's stories.
And David, if you were to give any advice to people that were looking to come on the program, I mean, I think a lot of people that are considering a qualification like this generally can be nervous about either the time commitment or possibly, getting back into academic study and writing and all that side. What guidance would you give to anyone here tonight that's thinking about it, that might be slightly nervous?
Yeah, it's not as hard as you think it's going to be. I suppose you're well supported. There's tutorial every week. There's a discussion forum there every week. If you've got extra queries with the tutors, you can get in touch with them via email. Like Pam that we've just had for the last module, I don't think she sleeps. She's replying to emails, got 24/7. She's fantastic. There's help with the academic side of things, with the essays. So the essays, we've had drafts to do for the 2 that we've done in the 2 modules I've done, and we've had really good feedback from that. That's been very helpful. There's online guides about how to do academic writing. I think part of that on the away weekend that you were doing, I'm not quite sure if you're going to do that with this next cohort.
It'll be a challenge.
Yeah, but even that, you're pretty well prepared for it.
Yeah.
As long as it's just that bit of consistency, just if you can just get into a habit of just doing a little bit of reading each week, and it just builds. And before you know it, you're reading studies, the original studies about the latest drugs. It's bizarre. You never would have thought that you'd be doing that and analysing it and making your own opinions on it.
And I think it's funny you say that. I've got one of the slides later where we asked people that did the course first in 2016-17. So they're 3 years graduated. We went back to them earlier this year and asked them, actually, right, looking back now that the study element is a distant memory, actually what impact has this had on your career and on your patient care? And one of the questions was on your ability to just read original literature. You're not waiting for the interpretation of it, you're just going straight to source. And again, the statistics in that are fantastic. But look, I'm conscious of time, and we're going to try to get everyone out on the hour as close as we can. So hopefully we'll get Paula's mic working and come back to her slightly later during the talk. But Stephen, could I hand over to you and your extraordinarily fancy slides?
Sure.
So if I spotlight video, Ian, is that Stephen's video up for everyone now?
It is, yeah. Well, it is for me anyway.
Perfect, brilliant. Off you go with your fanciness, Stephen.
Okay, well, thank you very much, Dermot, and many thanks to the many people who have actually taken time out of your busy schedules to hear about the Masters of Science in Diabetes Care that we offer here at the university. And I'm just going to spend no more than 20 minutes just going through some of the aspects of what we have as our offering. Now, diabetes itself is very important, and we all established that this is an important area. Otherwise, we would not be here. But in terms of the world epidemic, it is the largest world epidemic that we have. And this graph actually just illustrates that every single country is significantly affected. There's not one part of the world that escapes this. And it is actually increasing. Globally, we have approaching 400 million people who are living with diabetes, and the predictions are that this will rise to just short of 600 million just within the next 15 years. But the very sobering fact is that at least 68%, close to 70% of people over the age of 65 will actually die from diabetes as a result of the classical risk factor of cardiovascular disease. And if we are looking at this in terms of the UK, we looked at it globally, but within the UK, we currently have in the region of around 3.2 million people with diabetes, but that's estimated to rise to 5 million just within the next 5 years. So we are looking at increasing requirements to update our knowledge in this area. The sad thing, as I just mentioned in the earlier slide, but the sad thing is that whether we're male or female, on average, because the diagnosis of diabetes tends to be around the age of 45, 50, though we are seeing it more so in younger people. But let's take, for example, a person at the age of 50. If they have diabetes and no cardiovascular disease, they will die 6 years earlier with diabetes than with a person without that condition. So that is a sobering fact, but it is only sobering if we were not in a position to do anything about it for our patients. And this leads me to describing to you that not just the necessity of the course, but the flavour of this course that we offer in terms of the Masters in Diabetes Care. The course, as we've just discussed with David, it has comprehensive approach in the sense that you're following the IDF, the International Diabetes Federation curriculum. You're looking at not just type 1 and type 2 diabetes, but we'll also look at other forms, but type 1 and type 2 diabetes will form the majority of the thrust. You will be taught by experienced tutors who come from a variety of backgrounds. We have with our teams dietitians, nurses, doctors, lecturers who are themselves academics. Some of them are practicing in terms of their daily experience, and they're bringing all of this to bear on the interactions that they'll be having with you. So you can rest assured that you are being taught by someone who has experience, who is still at the cold front doing the work. The content of the course focuses on what we consider to be important within the UK, but also speaks to the modern management of diabetes, which I'll talk about in a second, the importance of individualising care and not simply just blindly following guidelines. There is important update in regards to this, and this is where we'll finish off in a few minutes' time. But the most important thing about this course, I feel, is its convenience. The online format allows the flexibility for busy healthcare professionals to be able to study, to gain experience, to gain academic knowledge, but also to develop what we consider to be one of the most important aspects of this level of study, a critical approach to looking at information. So you can do this at home, as many of you are watching this now, and there is a weekly tutorial which is recorded for those who are unable to actually make it at the specified time. So why Warwick? I mean, there are a whole host of places that deliver diabetes education. Well, I think we have a challenge and the solution, but the challenge is that diabetes care, diabetes management is changing so very rapidly. I spoke a few slides ago about the fact that diabetes is increasing in its prevalence worldwide, but so is the pace of change of the development of medications and approaches to treatment. So we say that 1 week is a long time in politics. I would argue that 6 months is a long time in diabetes care, and absence from the scene can make it very difficult to then know how to appropriately treat your patients. But the materials that will be used within the course are updated on a regular basis. We work with you and identify areas of skill gap or knowledge gap, and we aim to work with you to fill those. And we support you, not just by teaching you, but also to try and motivate you and help to keep you going throughout the course. So what is this experience like, the Warwick University iHeed learning experience? Well, the background to this, as I said, is that we're looking at the United Kingdom, we're looking at the numbers of people with diabetes. We're making this specific so that it is focusing on different parts of the UK. And you can see from this slide that there isn't a part of the UK that isn't affected. But if you cast your minds back, David alluded to the fact that he benefited from a workshop session. And in the pre-COVID era, we would have organised a face-to-face workshop session on 2 occasions. At the first semester, the first 3 months, and the second. There has been a little bit of a challenge in the sense of the requirement for social distancing. And we have sat down as a team to work out how we can deliver the benefits of the workshops, which I think are absolutely essential to ensure that you are embedded in the course. And you have the confidence to know that the online technicalities and any technical problems are sorted out, and you get a flavour of the course. And you know how it's going to develop. That's very, very important. So we have, I should say, developed a contingent solution to these workshop sessions, which Dermot will speak to in a second. Things that are covered in the workshop session, and I will speak about these in just the next 2 or 3 slides. We talk about a skill that is very important to acquire at this level of study. Now, what this level of study isn't is just an opportunity to gain knowledge. That knowledge is important, and we will give you that the knowledge base. But what we also want you to develop, and we would help you to develop, is to have what we call a critical approach to reading information. So not just accept it because it's there on a slide, or that is said by myself or Pam Brown or any of my other colleagues, but we welcome challenge, we welcome questions. An issue here, what is the difference between absolute and relative risk? Now, that can be extremely dry and boring if you were to sit down and look at it from a statistician point of view, but we try and make this fun. We use everyday examples to help to get over somewhat complex ideas. Again, the critical analysis of studies. There are a whole series of outcome trials ranging from 1972 to 2009. And a critical approach here is that you're looking at these studies, that they're looking at the outcomes in terms of favourable, neutral, and safety concerns. That's one form of critical analysis. It's not difficult, but once you get into the practice of doing it on a regular basis, it is something that will come very easy to you. So, onto the online experience. For each of the modules, which I will delineate shortly, you have learning outcomes. So it is very clear to you, we make it very clear what we aim for you to understand, the standards that we aim for you to reach by the end of that time. So you're not left in the dark in terms of the expectations. There is weekly tutoring, and it will take the form of what is happening tonight. So you will meet with one of the tutors. I am one of the tutors. We have quite a large number of tutoring group now, and there will be the opportunity, slightly different now because there are so many of you on that it wouldn't be feasible, but you have the opportunity to interrogate your tutor, to ask questions. This is like sitting in a virtual classroom. The learning modules are illustrated here. Now, there are 6 learning modules. Now, you will see that there are 7 on here, but the first one is basically what we call student orientation. There isn't any assessment on that. That's just basically rather like the first of the workshop sessions. But there then follows weekly modules, 6 weekly modules, which then look at core principles, which look at treatment options. They look at the management of diabetes, microvascular complications, which is a large area, macrovascular complications, and then we finish off with the management of diabetes in special populations. I'm just going to briefly now go through just a small vignette of the kind of things that you would be looking at. So the first module looks at risk factors for diabetes, and many of you will be familiar with what these are, and you can see this on the slide. But we won't make any, we won't seek to patronize anyone, we won't leave anyone behind. We'll make sure that everyone understands the principles, and those who do understand them already, we will seek to stretch them as well. We also will look at the prevention of diabetes in this module. And this is a fantastic study. This I've deliberately taken the title off, and hopefully some of you may realize that it refers to the diabetes prevention study, which tells us that metformin, in terms of preventing diabetes, metformin was inferior to lifestyle. Lifestyle intervention reduced the likelihood of someone developing diabetes by up to 58%. Now that's fantastic news. It's great for information to relay to our patients. But again, we'll look at that critically. What did they mean by lifestyle? What was the dose of metformin? All of these things become very important. There is another issue that we look at in this first module, is the diagnosis of diabetes. Well, we know that diabetes is based on a whole series of the presence or absence of symptoms. You can look at HbA1c, you can look at fasting blood glucose. We used to use the oral glucose tolerance test. But going back to the previous slide, the diagnosis of diabetes is a line drawn in the sand with a cutoff point of 48 millimoles per mole, or 6.5% in old money. And why is that? So we wouldn't say to you, well, this is the diagnosis of diabetes. At this level, we're asking, well, why? Why have they actually decided, the pundits, that this is the point at which we decide that diabetes is diagnosed? Why not at 6? Why not at 7? Some of you will know that it's the point at which we start to see retinopathy developing. And again, that's something that we'll discuss in greater detail. In the second module, we'll look at the management of diabetes. Now, the management of diabetes is not just about medication. It looks at all of these issues, which I won't go into in detail, but it just tells you how the multifactorial approach, we just alluded to the fact that we have people from different disciplines who register to do this course. And interestingly, it seems to make no difference in terms of their eventual result. The dietitian will do just as well as the doctor, as the nurse. It is all about bringing to the table your level of expertise and being prepared to learn from the experience. The management will also allude to some of the newer agents. This is the classical mode of action of the SGLT2 inhibitor. And we'll also not just look at oral agents, but we'll look at issues around barriers to injectable therapy. Now, you might say that this is the patient, you now need to go onto insulin, but that just could as well be the doctor or the healthcare professional, because many people have inertia in terms of putting their patients on treatment, injectable treatment, because they are concerned that they have a knowledge hiatus, a knowledge gap. And these are the kind of things that we would seek to actually cover. Very, very importantly, I said at the very beginning, we are not looking at slavishly following guidelines. We look at individualization of targets, and why do we, for example, look at being more intensive in some cases, less intensive in others? What is the evidence base for that? And then we'll also look at what we call the cardiovascular outcome trials. There's a whole list of these here, and it's related to the issue of the potential for our patients to die from cardiovascular disease, and the need to ensure that any medication choice that we make does not put them at increased risk. Later on in the modules, you'll be looking at the issue of large vessel disease, macrovascular disease. And I mentioned at the very start that the majority of our patients, sadly, if they're not managed appropriately, will actually die from cardiovascular disease. If they are unfortunate enough to have both diabetes and chronic kidney disease, CKD, then that accelerates, that increases their risk and their likelihood of mortality. But one of the things that actually comes across in the discussions, and it's really quite interesting, is that if we are not confident in terms of where we should be and what we should do for our patients, we tend to procrastinate, we tend to delay. This course is really aimed at enabling us and facilitating us to be at the point where we don't delay, we have a critical approach, we have the information at our fingertips, and therefore, rather than a patient being at risk of the consequences of delay, and here in this slide you can see that at 5 and a bit years, they're of poor control, and we're saying poor control is an HbA1c of greater than 7 or 53 in new money, that the risk of myocardial infarction is increased by 67%, the risk of stroke over 50%, heart failure by 2/3. These are risks that our patients should not be exposed to. I've mentioned that in the modules 5 and modules 4 and 5 will be looking at microvascular and macrovascular complications, and those are very large areas, so I won't go into any more detail there. But one of the aspects of the course that we've looked at was around a practical of foot examination, of being able to, this is again pre-COVID times, being able to pair off, to learn the issues of and the challenges of foot examination. This is not a skills-based course. We're not teaching skills, we're teaching knowledge and a critical approach. But the practical aspect of being able to look at how someone examines a foot helps to enhance that knowledge. Renal disease, I won't go into in any great detail here, but what I want to just finish off with is some of the other aspects of the course. So we don't only give you the weekly tutorials and the chance to actually feedback, but there is, and the learning outcomes, but there is also what we call guided reading. So you don't need to be hunting around, Googling courses to see where you need to focus. There is a clear, updated reading list for you to use, and you could just simply use that and you can guarantee that you'll cover all of the information that's required. We also will use case studies which help to enforce the knowledge, it helps to ground the knowledge, so it's not just a series of plain and prosaic data, but it's actually incorporated into the kind of details and cases that we'll see on a daily basis. The learning platform, and Dermot will speak about this shortly, is also supported by videos, and they are from people who we know and respect in the field of diabetes. I mentioned that we don't just give you the course, but we also critically approach the latest news, what's going on. DIRECT is a study that's only 2 years old, and it states that you can remit diabetes if you lose weight. And here, if you look at the far right, where with the oblong, the red oblong, patients who lost more than 15 kilograms of weight, they remitted their diabetes. It sounds excellent. It sounds wonderful. It sounds as if everyone should go out and do this. And at 24 months, still very good. But at this level, the critical approach would say, well, how generalizable is this? Large weight responders did well, but only half of them actually responded. And there didn't seem to be any way of predicting the responders or the non-responders. How easy is it to replicate the study in terms of this intervention with GPs? It has time, it has resource implications. The jury is still out in terms of whether this weight loss is maintained. And is it really remission? What do we define as remission? Who defined remission? So this is how we would actually start to critically analyze a study which other people might think, great, let's go for it because it's absolutely wonderful. We look at this level in a different way. There are a whole series of cardiovascular outcome trials which we would cover. And also we look at new guidance publications. Now this looks really quite complex, but this alludes to the new EASD, the European Symposium on Diabetes / American Diabetes publication. And lastly, we look at controversy. Now, we always advise our patients to stop smoking, but there is increasing evidence that sitting may be associated with a much increased risk of cardiovascular disease than we have seen in the past, which is one of the reasons why I'm standing giving this presentation. Anyway, I want to thank you for your attention. There won't be any time for questions because of the limitations of this, this meeting. But as you can imagine, if we were doing this in a tutorial, we'd be able to debate, discuss, and we will be able to both learn from this experience. Thank you very much.
Thanks a million, Stephen. really informative, and quite a lot packed into a short space of time. So what I'm going to do, and just by way of question, there's a bunch of us involved in the program management that are on this as well. So if you have any questions, if you put them into chat, as Stephen said, tonight isn't a night for getting into debates on the kind of the clinical side of it, but if you have questions about the program or anything like that, if you put them into the chat, we'll happily answer them for you. Now, bear with me 2 seconds. I'm going to go back to the presentation here. What I'm going to do for about the next 20 minutes will be to give you an overview of actually what the program is like from a participant perspective, and just give you a fairly detailed view as to if you come on to the program, what it will mean for you. You're going to hear about IHED interchangeably with the University of Warwick when we speak about this program. And just to give you a small bit of background as to who IHED are, we're an Irish company founded by a family doctor and for those of you from Ireland, he's from Tip in the south of Ireland. And what we do is we work with governments and healthcare ministries all over the world, particularly involved in primary care, but laterally in lots of other areas. But what we do as an online program management company, an online education company, is healthcare education, and it's all postgraduate healthcare. At the moment, across our platform, we've over 300,000 course completions, everything from CME up to postgraduate qualifications and family medicine residency programs. So our specialism really is in working with experts like Stephen to bring you programs in the most interesting, dynamic, flexible way in an online environment. The University of Warwick, who accredit this program, not blowing Stephen's trumpet too hard, but they're 10th in the UK, they're 62nd in the world. Warwick in Europe probably has the leading reputation for diabetes education. Their CIDC course and their masters in diabetes, they are the standard of diabetes courses to take. They're in the Russell Group in the UK, which is the top research universities in the UK. And the qualification you get at the end of this program is either a postgraduate diploma in diabetes or a Master of Science in Diabetes from the University of Warwick. There is no distinction between this qualification that you take in an online capacity and any other qualification you would get from Warwick. They are deemed to be equivalent. We go through the exact same examination rigor and everything else that an on-campus program would go through. So I'll just skip through that. In terms of your faculty, and I think the beauty of a program like this, and to David's point earlier about not being based in a university campus, is we can bring you the absolute best of tutors that are available not locally and internationally. So you have people like Colin Kenny, who is he was previously RCGP examiner, chair of the Primary Care Diabetes Society. He's based in Northern Ireland. He's tutored all over the world in diabetes. Dermot Quinlan is the National Diabetes Clinical Lead in the Republic of Ireland. Stephen obviously is with Warwick. Pam Brown, who you'll have, is Editor-in-Chief of Diabetes and Primary Care. Katie Reid is a phenomenally talented nurse who specializes in behavior change management, and she's actually written quite a lot of the content that's on the platform that you'll study. So that is 5 of 20 odd tutors on the program, and as David has alluded to, the tutors are fantastically dedicated to helping you to get through the program. In terms of what does it mean for you to come onto the program, the average age on our programs are anywhere between kind of 38 and 45. So most people are returning to study after an amount of time, and understanding, to David's point, what that actually means for you on a practical level is really important. So The first thing is, there's 118 people on this call. We break you into small groups, so you will get to know your group of somewhere around 20 people very well, and you'll bond as a group, and you'll get to know each other. I think the next part is actually the structure, and I'll go through this in a bit more detail. But the diploma part, before you get onto the master's project-based module, it's six-week modules, so it moves at a really good pace, but it's also got a really good structure to it. We say about 10 to 15 hours a week is what's needed. Every time we do one of these presentations and we ask the likes of David or Paula, they tend to give a slightly lower number, that it's probably in the kind of 5 to 6 to 8, and then it'll peak before exam times. I'm not sure. Paula, is your mic working now?
I think so.
It is.
Yeah.
So Paula, you're obviously coming from a slightly different perspective than David as a nurse in Ireland. What's your perspective on kind of balancing the program with your personal and professional commitments?
Yeah, well, and that was something I was quite nervous of at the start, but like David said, you definitely get focused. I think for me, on a Thursday evening, I know I give my entire evening and night to the course. So I'll join the tutorial for an hour and a half, and then I will go back over what we've done, and I'll read the learning materials that are attached. So I tend to spend probably a couple of maybe 3 or 4 hours on a Thursday, then sometime over the weekend. Then Monday, kind of the discussion is kicked off online, so you can participate in that. But really, it's so flexible, and I think, even if you have an hour at lunchtime on a Thursday, you'll tend to go on to see what everybody has been saying on the discussion before you join the tutorial that night. So I do think that it's probably approximately on the weeks that you don't have an assignment, it's probably, yeah, you're right, maybe 5 to 8 hours. When you have an assignment, it's definitely more, and coming up to the exam, you definitely want to put in
more
time. But it's all worth it, because you're going to learn so much. Even if you think you know a lot about diabetes, it just really pulls everything together, and you understand why you're doing certain things, why you're treating one patient with X and Y medication and the other person on totally different. So you understand why exactly, the individual aspect of diabetes, and that it's all not just, a target of 53, or, that we have to be flexible and understand what that means for our patient.
Yeah,
so
I think
for me, it gave me great perspective on really just understanding why we do things and why we ask patients to do them, and I've learned a lot.
That's brilliant, Paul. And I think, that concept of individualized care runs throughout the program, and that, involving the patient in decisions, and it is going to be a very individual journey for every patient with diabetes. I'll move on to, I think, but David spoke quite a lot about support, and I think that's it's a huge part that we're very proud of on the program, is the program managers and the tutors, and how much they look after each of the students kind of on an individual basis, and making sure that you're getting kind of responses to queries. And really, we see everyone that's on the tutorials every week, and kind of trying to head anything off at the pass that we can, and that then feeds into pass rates, and it feeds into feedback rates. So yeah, I won't spend incredibly long on these slides, because Stephen's touched on what the actual content of the program looks like. But effectively, each of the 6-week modules, each week covers a particular topic. So again, in terms of you structuring your learning, it's very set out. You know that module 1, week 3 is screening. You know that module 2, week 4 is insulin initiation, etc. So semester 1 is made up of the first of these 3 6-week modules, and semester 2 then, and what you can spot actually is we're following the patient journey. So we're going from kind of an overview diabetes and epidemiology of it, evidence-based medicine. So you're finding your patients, then you're getting into treatment, and you're getting into self-management, which is really looking at how you empower your patient to take responsibility for all those lifestyle factors in particular that Stephen spoke to, and that behavior change element. And what we're trying to do in module 3 is really give you a toolkit that you can draw from, that is evidence-based, that techniques that are shown to work more in getting your patients to eat healthier, move more, stop smoking, drink less, all those types of things. We then, in semester 2, get into management of complications. And so, nephropathy, neuropathy, etc. Module 5 is all focused on macrovascular complications and cardiovascular risk and managing that. And then, things like diabetes and pregnancy. People that have diabetes are living far longer. So old age is an issue of itself. Comorbidity is an issue. Diabetes and sports and travel, if people are fasting. So, really what you're doing on the program, on the diploma part, is you're following the patient journey through living with their illness. So that takes the 12 months of the postgraduate diploma. And if you exit at that point, the award you get is the postgraduate diploma. If you then continue on into semester 3, which is a further 8 months, we get into research methodologies, and you do your professional project. And this is what brings it up to the Master of Science in Diabetes Care. I love what Warwick do for the output of that master's. It's not a 15,000 word thesis that'll sit on a shelf like mine behind me and be read by no one but my father and my supervisor. The output is actually a conference poster presentation. So you do an A0 conference poster presentation, and you do a 4,000 word journal article in the style of the Journal of Diabetes Care. And the rationale with that is we want you to leave your MSc with something really, really tangible that you can actually submit and get credit for and get value for, and contribute to the body of knowledge in diabetes. And that's particularly relevant when people are looking at things in their own local context, be that in a nursing, nurses in Ireland, doctors in Ireland or in the UK, or if it's doctors in Malaysia. The beauty of this program is it's actually providing a really wide base for study in diabetes, and to add to the body of knowledge. So how does it work? The program ordinarily kicks off with a 2-day workshop at the start of each semester. The last time I was on a plane was the workshop in March for Warwick. The students that have started after that, effectively we've done a week. We've done the same induction over the course of a week, and the purpose of this is really just to get you up to speed with academic writing, to get you to know your group, and to get you very comfortable with what the program is going to do. To David's point at the start, each week then follows a rhythm, and on a Monday morning it'll kick off with a discussion forum post, and that will be a short case vignette usually that will describe a patient with a scenario and ask you what you'll do, and your group and your tutor will all kind of interact with that throughout the week. You then go through the online content in your own time, and as both David and Paula said, that can be, you've got 10-15 minutes spare and you just happen to read something. It's really easy to dip in and out of it, and it's kind of like Netflix, where if you're looking at something in work on your laptop and then you pick up your iPad at home, it knows where you've left off. Then once a week, usually on a Thursday evening for the UK and Ireland groups, you come together in your small group, not like this where it's very one-directional conversation, but the weekly tutorial, it is a debate. It's not death by PowerPoint. It's not someone lecturing at you. It's bringing that week's topic to life through case studies. And then you've got your assessment and your exam. So each module has an essay. So at the end of the module, you do your essay, and then at the end of the semester, so at the end of semester 3 and at the end of semester 6, you have an exam. And you do all of this online, and again, there's huge support around that academic side of it. And as you'll see later on as well, the pass rates are extraordinarily high in this program. We've just graduated our first group from Warwick, from the new program in June, and we had a 74% distinction level. So people are getting on phenomenally well in the program, and we get really, really high quality participants on the program. They get a really good education, and they do very, very well in the exams. This is just a screenshot of actually what the platform looks like. It's really nice. It's really interactive. It is, there's lots of imagery, there's lots of video. What it's not doing is getting you to read page and page of flat text. There's tons of case studies, and there's tons of different types of case studies that really get you, as Stephen said, to apply your learning. And this is all about, clinical decision making, and are you able to put into practice what the latest guidance is saying. Lots of video content throughout. So as content to go through every week, it's pretty stimulating. The platform is a joy to use. Everyone knows what a Zoom tutorial looks like. 6 months ago, that slide might have been necessary. It's not now. In terms of support, there's a huge support network around everyone doing this. Everyone is a health professional that is working full-time, studying part-time. Average age is late 30s, early 40s. Most people have families. Lots of them have young families. So the support that you get around the program is really important. Stephen and Colin, as the program leaders, are brilliant. The tutors are phenomenally dedicated. You then got, people that need us are matched up with a mentor. Ian Rowe, who's on the call tonight, leads our course management team for diabetes. His team are fantastic. The most underutilized people in the whole program are the tech support guys. The stuff just works. In terms of the experience then, so there's been 380 odd people that have been on this program so far from all around the world. The statistic here of 88% student engagement, it's reasonably consistent across the years. And what it says to me is, to David and Paula's point about rhythm, that most people are able to get into a routine and do really well. What I look at as well, though, is nobody gets to 100% of everything, and it's unrealistic to think that you will, but the program has the flexibility built in to allow for that. The support in the organization always gets glowing feedback, which is fantastic. What it comes down to is the pass rates, and the first time pass rate in this program is 92%. And some places might balk at that. We look at it as high quality participants getting a good experience and then doing very well in an assessment. And we are amazed continually at the quality that is produced by people off the program. So by the time you get to modules 4, 5, or 6, some of the essays could be published work. They're phenomenally good. This is what people that have done the program tell us they get out of it. So we do surveys after the program. We do a pre and a post, and these are just some of the things that you'll deal with when you're managing patients with diabetes. And most of them, you can see some of the challenging ones, like helping someone overcome obesity. It's a huge improvement in the level of confidence that people have in doing this before and after they do the program. That's probably one of the more challenging ones. Initiating injectables, recognizing type 1, recognizing emotional distress. Like, to Paula's point, you'll come off the course with all of this kind of brought together and tied together for you, and have a really rich, deep understanding of managing diabetes. I alluded to this one earlier. This is the first group that qualified off the program they did it in 2016 and 17. We went back to them and asked them, right, 3 years post qualification on a scale of 1 to 5 of large positive impact to large negative impact. How do you feel the program has changed, your level of patient care, your career, your reputation with colleagues, and then to the point David was making about just going straight to source research, your understanding of research papers or clinical trials, and every one of these metrics showed a really, really positive impact of the program. So, when Paula speaks to how the program helps, consolidate and synthesize all that knowledge in diabetes, this really speaks to that. So we're coming towards the end. We've talked lots about this, but there's lots of different blended elements to the program. Some of the 3D medical stuff is brilliant. To me, the lifeblood of this program is the tutors and the discussions that you have with your tutors, both on the discussion board, which you dip in and out of anytime you want, and then that weekly tutorial where you come together in your group and get to the heart of whatever that week's topic is. It's hugely powerful. So down to some of the kind of the practicalities of it. So entry requirements into the program. So evidence of proficiency in English is the program is delivered in English. So having fluency in English is a must. However, we don't, for anyone who's not a native English speaker, we don't ask for an IELTS test or anything like that. We simply, we do a telephone interview, and that's enough that we can get a very good gauge on it. You need to be in a clinical setting. It says medical practice there. I think clinical setting is probably more appropriate. Once you're in a clinical setting that you'll see people with diabetes, that's what we're looking for. And similarly, that you've got a health science discipline. And that's equally for nurses, for dietitians. Once you've got a health science background, you're very welcome on board. We'll ask you for a copy of your university transcript, a personal statement, a letter of reference from an employer or an academic, and ID. We do limit the places. There's huge interest in the program. What we don't do is just kind of keep piling people into it. So we run it into small groups. We are going to take kind of 2 groups on in October into the UK, and there's a phenomenal level of interest in it, which is brilliant. We're delighted with. In terms of fees, then there's the set fee. The kind of the book price is €9,950, 9,000 sterling. There is a 25% bursary on that, which brings it down to €7,500 and £7,000. There is an early bird discount on that, which is quite significant. That closes on the 10th of August. So if you are thinking of coming on board and you want to avail of that, there's a hard stop on that of the 10th of August, which significantly enough brings the price down. Effectively, you pay €1,000 deposit to secure your place. The last intake was oversubscribed. We imagine this one will be as well. So, our recruitment advisors are going to reach out to everyone after the session over the next couple of days and just answer whatever questions you might have, and see if you are interested in coming on board. So I'll stop pretty much now. It's just to summarize an awful lot of information that's been given to you over an hour. It's a 12-month postgraduate diploma or a 20-month Master of Science in Diabetes. The next intake is going to kick off in October for UK and Ireland. The award that you get from Warwick, it's top 10 UK university. It's recognised in the UK, it's recognised in Ireland, it's recognised everywhere else in the world as well. I think the part-time nature of the program, the design of the program that acknowledges that everybody is a full-time health professional and a part-time student is really, really important. To Paula's point, I think this is career enhancing. It really brings together diabetes management for you. And, the title of Diabetes Care was quite deliberately chosen. What we want you to get out of this program is that you're far more confident in giving diabetes care to your patients. we run this really informally. They're outside of the assessment and the exams, which are, as you would think they are for a university. It's a really, really nice bunch of people that care passionately about diabetes and genuinely have a bit of fun in delivering the content and looking after each other and supporting each other. So the link is there to apply, but you're going to get all of this stuff from the recruitment team anyway. So I am going to stop sharing here and go to kind of questions which are coming in on chat and see.
We kind of answered them all, Dermot, just to let you know. We've had
yes, Rebecca has been exceedingly efficient.
there's more on fees, really. That's the one that everybody's just obviously the most important one. Yeah. So 6,300 is the postgraduate diploma. If you want to go back to that slide for a minute, Dermot, maybe we'll keep it up so there's no confusion. And then it depends on whether you're in Ireland or the UK, it's either 4,000 sterling or €4,500 for the additional master's section of the programme.
Yeah.
One of the candidates here has been asking what are the career opportunities after doing this. The PGDip or the MSc, it varies by region. Obviously in the United Kingdom, if you're a GP, you can become a GP with a special interest. If you're a nurse in the United Kingdom, you become a DSN, which is a diabetes specialist nurse, so you have a good opportunity of becoming one of them. In Ireland, we don't have a GP with a special interest qualification in Ireland, but and in the nurses in Ireland, you have to have a level 8 qualification under the Irish framework to become a DNS. We call it the opposite way around in Ireland. So the diabetes nurse specialist, obviously that's not the only thing you have to have. You also, of course, have to apply for the position and be successfully interviewed for the position, but level 8 is compulsory, so you must have that. And so we meet with the academic requisites for DNS status in Ireland. So I suppose Dermot touched on it very briefly previously, but our graduates were now enrolling between 200 and 300 graduates around the world on this programme per annum. And our graduates have gone on, the doctors in particular have gone on to set up on their own diabetes clinics. We have doctors now and clinicians both that are leading in diabetes, strategic diabetes groups at a national level and governmental level, and therefore kind of influencing diabetes policy. So we're very proud of what they have achieved so far. And I suppose it's just really becoming a specialist and really focusing in on type 2 in particular, but diabetes as NCDs, and using some of the, I suppose, the chronic disease management theory across other non-communicable diseases.
And again, Rebecca, I go back to that impact slide of what people said that they got out of the course, and when we asked them about, patient care was massive. Lots of people saying very positive impact on their career, and I think and reputation with colleagues. I think this type of qualification, it's very hard to say. There's obviously if you're going to become a diabetes specialist nurse, there's a very fixed trajectory that you can set your sights on. I think for a doctor, it's kind of to David's point around, this, it gives you an area of specialism outside of kind of bread and butter, general practice medicine. Obviously, for those that are kind of dietitians, nutritionists, there's a whole range of roles around a patient with diabetes. So I think a lot of it depends on what your background is and where you want to kind of veer your career. Stephen or David, do you want to jump in on that?
It's interesting. I'm interested in the wide-ranging questions in terms of the effect of doing this degree of study. Now, for doctors, so I will speak as a doctor. We're trained basically to be clinically aware, to be able to manage risk, to be able to make diagnoses and to treat people, which is part and parcel of our professional skill acquisition. This course there is knowledge based to it, but it is not a skills based course. It is anyone who achieves a master's degree, whether that be in any level of Masters of Science, they're showing that they've achieved a level of study that is academically recognized in terms of being able to understand critical analysis and to be able to publish work that others can actually benefit from. So you are not just, as a doctor, treating patients, you are actually then in a position where you are contributing to the body of evidence that there is out there to enable others to benefit. And for me, it would make that kind of person a lot more attractive in terms of working with them in the future. If I wanted someone to be head of a department, if I wanted someone to join a practice, that extra level of skill, of understanding would be something that's very attractive.
Yeah, absolutely. Paula, there's a couple of questions coming in here asking, you know, from a nursing perspective, what the benefit of a qualification like this is. Would you give your perspective on it?
Yeah, well, I think the benefit is, you know, the quality of care that you're actually going to provide to your patient. And also, I mean, I suppose I've had a lot of experience working in diabetes. This has really, you know, helped me to pull it all together. And hopefully, you know, as Rebecca said, I would be probably looking at becoming a specialist in the area. So there's lots of community nurse positions in Ireland. There's so much focus on it now with chronic disease management. So I think it's really going to be, you know, positions that are going to be very sought after. You know, you can go on to become an advanced nurse practitioner. So like it's a huge benefit to your career.
Yeah, absolutely. Thanks a million, Paula. Let me see what other questions are coming in. Do you have many pediatric nurses on the program?
Pediatric nurse?
I'm struggling to think. I'm struggling to think of a
I was
pediatric
one.
nurse.
I was one.
Yes is the answer.
Yeah, I think I'm probably, well, I just have a dual qualification in peds, but I think, you know, the focus is probably in primary care and type 2, although you do touch on type 1 and peds and gestational diabetes as well.
Yeah, and gestational diabetes is becoming, certainly in some parts of the world, becoming a huge issue. Can a mental health nursing role? Yeah, absolutely.
Yeah.
Once you have a health science background, you know, you'll be welcomed on board. So absolutely. And you know, we didn't really touch on it tonight, but the interplay between diabetes and mental health is enormous. You know, it is. There's a huge association between depression and diabetes. So yeah, absolutely valid.
And there was, Gordon did ask a question earlier. We had a lot of smiley faces because we had conflicting answers from myself and Ian on the word count in the essays. Is it 2,000?
2,000 word essay.
2,000.
It's a 2,000 word essay.
I stand corrected, Gordon. I've just put an extra 1,000 words on every word. So I'm sorry about that. So I will remember that.
2,000 words sounds like an awful lot. If you indulge me for about 2 minutes on this. So the first essay is going to ask you to look at diagnosis and screening. And there's two parts to it, and one part is worth 60% and one part's worth 40%. So you've got about 1,200 words to write on the diabetes prevention strategy in your locality, or in your setting. So in Ireland or in the UK, and Ireland doesn't formally have one, which always makes for an interesting essay. But by the time you break that down into 3 or 4 parts, you're kind of writing, so your 2,000 word essay suddenly becomes a 1,200 and an 800, and there's 3 or 4 parts in each. So you're kind of writing a few hundred words on each part of it, which are backed up by some references. And I think this goes to David's point right at the start of, it's not the mountain you think it is when you first look at it. And in the induction session, we put up the module 1 essay title, and people take a gasp of breath in, and then we spend about 20 minutes breaking it down as to, well, how would you answer that, and how would you answer that, and how would you answer that? And everyone goes away a lot calmer afterwards. So, you know, it's the essay is not something to fear, nor is the exam. And I think, you know, the pass rates that we spoke about earlier are indicative of that. You know, the average grade in, and I'm going to pick him out because he's here, the average grade in David's group on your module 1 essay was 72%. So, you know, that is a phenomenally high standard. It's not that Stephen and his colleagues are easy markers, it's that the standard that's produced is really, really high. So do not fear the assessment part of this. It's important, it's necessary, but it's not a barrier.
And Akeem is just asking about the graduation ceremony. Obviously, traditionally, we would have had a full graduation in the University of Warwick, and we do have local graduation ceremonies all over the globe where all our particular groups are based. I am not sure during COVID exactly how the graduation ceremony will take place. Being very candid.
I think that's, I'm not sure that's been decided as yet, but I think one of the points to make for students or would-be students is that even though this is delivered online, your degree has the same validity as if you were in full attendance on a face-to-face basis. So it is no different than anyone else studying at the University of Warwick.
And it doesn't say distance or blended learning on your certificate whatsoever. Dr. Rata has asked a few times, so we should address it, but we're not in the business of really trashing other university qualifications, but just to give you an overview of how we are similar, and maybe the comparison between Leicester or Cardiff or some of the other universities offering a similar program. We are the only obviously the University of Warwick rankings are very high and very prestigious, and it has 20 years reputation in diabetes education and has graduated over 14,000 clinicians across the United Kingdom and Ireland in diabetes education. So they really, I suppose, a stalwart of diabetes research and diabetes education in the United Kingdom. So that would be the first. So the ranking and tradition of diabetes education. Moreover, we are the only institution diabetes program that does the face-to-face tutorials every week. So a lot of the others are self-study and they are asynchronous. So you're left more independently to study than you would be on our program. So there is a lot more emphasis on touch points and interactivity with your group and interactivity with your tutors on our program. Just being very candid, I did see for the first time another of the institution's learning systems recently. And I'm not being overzealous or over egging the pudding when I say there is zero comparison between our learning environment and some of the other offerings in terms of interactivity. We spent over €500,000 in creating this program, just to let you know. So that in terms of reality, in terms of interactivity, in terms of hot quizzes, the way you learn information on our learning environment is it's extremely engaging and palatable. We've hyperlinks that link to very extensive formularies and journals and a very extensive library, but it's just a very easy way to just digest information. And we can, if anybody's interested, send you one of our open source sections on retinopathy, so you can see for yourself. It really is extremely interactive. So they would be kind of the main ways. To me, myself personally, the competency-based assessment is something that the other institutions don't do. But I think it's the level of touch points with the individual, with your class and with your tutors. You are absolutely not left in isolation to study alone. And that's very important in distance education, that you're not left to self-motivate all the time. And I think that's our major differentiator, to be honest.
Yeah, I'm just going to jump in, and obviously I'm logged in as an administrator, so this is going to be a slightly different view than a given student, but just to show kind of what some of the interactivity here looks like. So I'll go into retinopathy, which again you can go into in your own time because it's available free. But so each of the 6 weeks of the course has, you know, each module has 6 weeks. Each of the weeks has a topic. when you go into the topic, you know, the first thing you're going to notice is it's a very engaging, nice visual experience. There's learning outcomes that are set for every single week, and you know, this guides you in terms of what you need to know. It guides you in terms of what you're going to be expected to know and potentially examined on. There's tons of interactivity in the platform. There's reflective kind of tasks built in. There's lots of kind of quiz options in it. But you know, as I said, there's video animation throughout. There's loads of little kind of pop-ups that tell you exactly what things are. And then, you know, there's some really cool, I'll just turn the volume down on this because it won't translate too well. But, you know, there's some really cool 3D medical animation that really demonstrates well exactly what's going on. You know, in this case for retinopathy, when the blood vessels, they have to go in single file. So then if something happens with glucose, you know, it's a very, very engaging visual experience. We've got absolute world experts from, you know, everywhere from Oxford to Cambridge, giving video. And of course, like I think David Matthews here, who's a leading light in retinopathy. So it's a really engaging experience. And as Rebecca said, I think that the key differentiator of this program is the blend between the quality of the platform, but then what the tutors give you and what the support looks like. So, you know, there's lots of options if you want to study diabetes, but we think this is definitely one of the better ones out there. So sorry, I've gone on. What other questions do we have?
Abdi Hakim is just asking, there are the students recognized as University of Warwick students accessing resources like library?
Yeah, so you are recognised as Warwick student. It's not quite in the same way, but you have all the library access that you need. You have everything contained within the platform. CME, I presume you mean CME points for if you're a doctor and you want to submit that to the RCGP, and yeah, absolutely. So the standing of the program is the same as any other program in Warwick.
Jamie was asking there earlier, she doesn't have evidence of English proficiency.
That's fine.
Maybe you don't require it if your qualification was in the medium of English, or you are currently working in UK environments, so you will not require English proficiency for this program.
We'll be licensed to start initiating insulin. If you're a general practitioner, absolutely. You know, if you're not a general practitioner, then the answer would be no. But if you're already a general practitioner practicing in the UK, then I think the only thing that would stop you putting someone on insulin would be the confidence and know how to do it, which the course will definitely give you. Stephen, is that fair?
I think it's fair to say that. We also say that if you are initiating insulin, you do need to be doing it with some degree of frequency. So that if, for example, I was only initiating insulin once every other month, that would not give me enough experience, even though I'm clinically qualified to be doing that for my patients on a regular basis. So whilst this course will give you the knowledge to be able to do that, you do need to ensure that you are doing, as with any clinical procedure, you need to be doing it on a regular platform so as to maintain those skills.
Yeah. What else have we missed in questions, or have we?
I think we've got them all nearly.
Yeah, I saw someone ask me if they're a health coach. I think there's a whole underpinning. You know, if you're to split what this course does in terms of diabetes prevention and management into two very big blunt buckets. One is clinical, medical. The other is the behavior change, lifestyle, patient motivation side of it. And I think in terms of a health coach coming onto the program, that is the area that's going to be of most interest to you. And certainly there's an awful lot of that within the program. There may be parts on the clinical side that you'd want to look at the curriculum and make sure you'd be comfortable with, but yeah, absolutely, there's a huge emphasis on patient management and self-management within the program that will be very relevant. Okay, I'm conscious. I said we'd get out within an hour, and I obviously lied. But it's been a huge pleasure to talk to everyone. Been a brilliant amount of questions. Particular thanks to Paula and to David and to Stephen for their time this evening. It's been great to get the kind of unvarnished version of what people that are actually on the program have to say about it. So your input's really appreciated. Our education advisors will reach out to everyone in the coming days, and basically, if as I said, that early bird deadline is there. As our last course, when it fills up, it'll be full. So if you are interested in coming on board, ask the questions you need to, and then go about applying. So,
and just to follow up on what Dermot said, that you will get the email tomorrow, which will have a recording of today's webinar, and you will also get the slides from the webinar. A few of you have asked for them, so that's no problem. We can send them on to you. And within that email, you will also have an apply now and pay your deposit. The deposit is €1,000 or 1,000 sterling to secure your place. And places do fill up and are filling up very fast, which is wonderful. And you will be contacted by our education advisors personally by phone in the coming days to see if you're happy with the information, if you'd like to proceed to application.
I would just like to just add that it really is a fantastic and enjoyable experience. I often say to people, look, have fun in what you're doing, and this is not a drudgery. It is fun, you'll learn. You'll have challenges, but most of all, I think you'll find it an enjoyable experience.
And Hema just said, how many GPs do you get in each semester? Hema, globally, the GPs are our largest group. It's around 70% general practitioners on the programme globally. It does vary by region. There's a lot more kind of even weight with nurses and general practitioners in Ireland and the UK. But that's just a testament really to the fact that Ireland and UK nurses are prescribers and have a large burden of management of non-communicable diseases, whereas in some of the other jurisdictions we work in, they do not. So there's a wonderful mix, and we pride ourselves on excellent professional education and working as a team. So yes, Dr. Ratta, the deposit is refundable. And I think was there any other question there? Are certificates okay rather than transcripts for degrees? I'm not sure what that means, Ruth.
Sorry, I've missed that one, obviously.
Are certificates okay rather than transcripts for degrees?
Yeah, that's fine.
Yeah, that shouldn't be an issue. Wonderful.
Yeah, that's absolutely fine. So yeah, that's it. The piece of parchment rather than the detail of the modules. That's absolutely fine. Just the overall degree certificate is all we need for admission.
And just, I know Jamie said there, I just have to figure out how I can afford the fees. Just to let you know, I mean, there is in the United Kingdom in particular excellent support for clinicians. If you're in secondary care, you can go to your trust and they usually have an excellent education fund. If you're in primary care, the CCGs have training funds, and we have a lot of clinicians that have been funded through the CCGs. So that there is a very nice mix. Failing that, in the United Kingdom, it's the UK Student Finance, and where you can get a low interest loan, and this programme is listed with a particular code on the UK Student Finance website, and we can give you a letter which has the code. So you can just go in and apply for that if you fail to get funding, Jamie. But a lot of the nurses, particularly on the programme, both in Ireland and in England, have received some form or some element of funding, particularly in secondary care.
Jay, actually, there's two interesting questions after coming in. So, if you don't have a degree, if you're a nurse without a degree, we have in the past couple of months got approval from Warwick that we've got a very straightforward interview process. That it's not kind of recognition of prior learning, but if you're a nurse whose route into nursing did not involve a degree, but you've got experience, then that is absolutely fine. We'll do what'll be a reasonably short interview just to make sure the program is a right fit for you, and then you're very welcome in. It would be pretty discriminatory to think that people that have significant experience with as nurses with diabetes wouldn't be able to join the program. There is support. We have a student at the moment with pretty severe dyslexia on the program. They're getting on great. Supports are there. They're pretty standard in terms of essays and exam support. So yeah, that's there, and that goes through Warwick Central processes again, like any other student on any other program. Okay, fantastic. Listen, thank you all so much for your time this evening. It's been really, really interesting. And look, hope to be welcoming you onto the program in a couple of months. So thanks a million.
Thanks so much. Take care.
Bye-bye.
Take care. Bye-bye.
Bye.